Good. So thank you very much, everybody, for joining today. Today we're gonna hear the amazing presentation from Anna Babl. Just a very quick introduction. She is an assistant professor at the clinical psychology department at the University of Leiden. She's gonna tell a little bit about herself. All what I can say is that she's an amazing professional and an amazing person, and I'm very, very excited to hear her presentation about therapeutic alliance, rupture, and repair processes. So yeah, Anna, the stage is all yours.
Thank you very much. Thank you, Franze, for inviting me to give this webinar for SPR. And it's nice to see some familiar faces and also some faces I haven't seen before. I will start sharing my screen. And please let me know if you can all see it okay. Is that a yes?
Yeah.
Yeah. All right. Great. Then welcome, to understanding and training the therapeutic alliance via rupture and repair processes. I am right now not seeing you guys, so I will just quickly make sure this is actually working. Right. I would actually like to start with a brief mindfulness exercise to get us started. And I hope actually that in the end of today's webinar, you have an idea why we did this mindfulness exercise to kick us off. So I hope you can all find a comfortable position in your chair. I invite you to close your eyes if you feel comfortable. And just start by taking a couple deep and even breaths. And invite you to just notice and acknowledge whatever is coming to mind, wherever your thoughts go. Make a mental note of whatever is coming up. Don't try to change anything. Just accept it. And when you're ready, come back to your breathing. When you're ready, take another 3 deep breaths. And we'll come back to the here and now. Well, for the rest of today's webinar, this is what I would like to cover. First, I will give a brief introduction into rupture and repair, and also acknowledging that not all people have the same pre-level knowledge. I will dive into it a little bit. Then we will talk about the 3RS, a way to operationalize rupture and repair processes. I will give you an overview of the current empirical evidence we have for the effects of rupture and repair. And in the end, I will round it up with a glance into alliance-focused training, a way for therapists to learn to build and maintain the therapeutic alliance. I'm sorry, but technology is giving me a bit of a hard time. I'll stop sharing and share again in a second, because I can currently not see anyone at all, and that's a bit difficult for me to present and get an idea of what your reactions are. And fix it, unfortunately, but just interrupt me if there are any questions. So the therapeutic alliance is the quality of collaborative relationship between therapist and client. And we know that it is one of the most robust predictors of psychotherapy outcomes. It accounts for 8% of outcome variance. And we also know that early improvements in the alliance have a very positive effect on a patient outcome. We think of the alliance, or it's most typically conceptualized in a three-partite way, as part of agreements on the treatment goals, then the collaboration on the treatment tasks, and also the emotional bond. Then, on the other hand, we have alliance ruptures, because we know that the alliance is not a static, continuously increasing construct, but we know that it is characterized actually by a quite unsystematic pattern. So alliance ruptures are defined as deteriorations in the alliance. And here again, it could be a lack of agreement on the goals and tasks, or a strain in the emotional bond. We know that alliance ruptures are common events, and depending on whom we ask, the patient, the therapist, or observers, they are actually happening in up to 100% of therapy sessions. That also maybe gives us a hint that ruptures aren't these big events or breakdowns in the alliance, at least not necessarily, but they can actually be quite subtle and difficult to recognize. And I think what we need in order to address a rupture, of course, is this recognition or awareness that it is happening. Alliance ruptures, or there's two types of alliance ruptures. One are confrontation ruptures, which means that either patient or therapist are moving against the other or against the work of therapy. And I think confrontation is typically what we think of when we think of a rupture. So kind of a clash. There are different confrontation rupture markers. For example, complaining or criticizing is very typical, controlling or pressuring, and pushing back. And again, I just want to highlight that they can always happen from both sides, or be initiated from both sides, the patient and the therapist. A very concrete example could be, for example, that a patient says, that's nonsense, this is not the real issue, to something that a therapist suggested. And then on the other hand, we have withdrawal ruptures, and they are defined as moving away from the other or the work of therapy, and often they are more subtle and more difficult to detect. So this is more a reaction of kind of closing off and distancing. Could be, for example, going silent or using rather vague and abstract language. And often it's masking aspects of one's experience. So, for example, telling a very emotionally heavy story while laughing. And often we need that in a way, because if we go into it very much, then maybe we are emotionally overwhelmed. Of course, psychotherapy typically is complex, so we know that also withdrawal ruptures and confrontation ruptures, all these movements against and away from the other, often happen simultaneously, and that's what we call then mixed ruptures. If there's alliance rupture, of course, ideally, we might think that there should be rupture repair in response to it. But for rupture repair to happen, a lot of other steps are necessary in the middle, which, for example, are awareness of a rupture taking place, then being able as therapists to regulate our own emotions so that we can actually respond in a sensitive way, and also in a way where we are curious about the other's experience and are not so ridden by what our experience is in the moment. That's also why I was thinking starting with a mindfulness exercise might be interesting, because that's actually a way to train the awareness, emotion regulation, and curiosity and non-judgmentalness. So repair then would be defined as a way to renew or strengthen the emotional bond, and potentially also to resume collaborating on the tasks or goals of therapy. And once more, we have two types of repair strategies. One are the immediate repairs. Typically here we address, for example, a disagreement on tasks or goals of therapy, and often it's a misunderstanding that we can actually solve quite immediate. And then we have the expressive repair strategies, and those are the ones that we often are more interested in when we think about repair, I think, because they are happening when we actually go into a rupture and start exploring it more and giving it some more room. I will talk a little bit more about what they are later on, so I will keep it a bit shorter now and get right into the Rupture Resolution Rating System, the 3RS, which is an observer-based measure for rupture and repair. And it is already the second edition and is seen as the gold standard, I think, of at least coding the rupture and repair in sessions. And this was developed by Catherine Eubanks, who I had the pleasure of doing my postdoc with, together with other colleagues. And in this version, there is actually markers for rupture and repair, or for ruptures and repair processes on both the patient and the therapist side. So once more, this is really something co-constructed, and usually both take part in an occurring rupture. It's really something extremely interpersonal. This manual is then applied to video or audio recordings of therapy sessions typically, and they're in 5-minute segments. So usually you would watch 5 minutes of a therapy session and then start coding. And I will show you now the coding sheet only. But in the manual, there's actually a lot of great examples from the clinics that are anonymized and that might help people who are interested in trying to better recognize ruptures when they occur. This might actually be very helpful also for clinicians. So in this coding sheet, we see a scale is used from 1 to 5. And here is, we always code between not salient in a segment to very salient in a segment. And I think it's very important that we have a good way of rationalizing rupture and repair so that we can actually study it better and measure it. In this new version, also a working together subscale was included in the 3RS, which I think is very nice because often we want to associate rupture and repair with alliance and the quality of the alliance. And usually this was never possible in a very fine-grained way because we had a maximum of session measurement of the alliance, but actually 5-minute measurements of rupture and repair. So we could actually never use those really fine-grained codings and always use the overall session score. So a lot of information was lost, and this gives us some new opportunities. And here we code the rupture markers, and they are divided into patient moving away and therapist moving away, which is the withdrawal, and then patient moving against and therapist moving against. And you see a lot of different specific markers. So for example, shutting down, which could be a minimal response. An extreme example is maybe a patient not responding anymore at all to what a therapist is saying. We also have patient avoidance, which could, for example, take the form of abstract communication, which I think is something that we experience a lot in psychotherapy sessions, that when something becomes maybe too intense for a patient to tolerate, they might talk about an example that happened to someone else, or talk about it in a very abstract way. And patient masking their experience. I already gave an example. Then we have the same for the therapist, and we have the confrontation markers where it's complaining or criticizing. This can be either the activities of therapy, the interventions, treatment parameters such as treatment frequency and treatment progress, but it can also be the therapists themselves that they are criticizing. Then we have pushing back. This is maybe when we make we may take a guess of something that's happening to a client, a hypothesis, put it out there, and the patient really rejects that idea or defends themselves, saying this is not true at all. And then we also have controlling or pressuring, which could be, for example, if we can't see each other twice a week, I'm going to quit and I'm just going to get worse. Then we, of course, also have all that on the side of the therapist, where sometimes we might even unintentionally also criticize. Sometimes maybe we also use confrontation, of course, because we think it's necessary to help a client. So I think there's a bit of a thin line. And then we have repair strategies. And I think here it's really important to just say this is what we intend to do. This doesn't necessarily mean that it does resolve a rupture or contribute to repair of a rupture. Sometimes our repair strategies even lead to a new rupture with a client. So this might not always be successful, but this is things that we might intend and that also patients might do intend. So here we have the immediate repairs on top. For example, we can discuss changing the task or goal of therapy. We can maybe illustrate why we think a task is still relevant for people to do. For example, maybe diaries or homework, things that happen a lot in CBT, I think. And I think there's often a lot of non-compliance, so maybe we need to, again, illustrate that doing something 1 hour a week might not lead to enough change as opposed to really practicing things in everyday life, and this might be helpful, but we might also say like, okay, for someone, it might be hard to sit down and write things down. Maybe they can do it digitally or find a different way of doing a task that might better suit them. So I think there's different possibilities. And then I think the really interesting part is happening at the second part of this page. So this is the exploring the rupture and the expressive repair strategies. Where, for example, we might validate the other's experience. So this makes sense that you're feeling this way, for example. Can be an invitation to engage in an exploration of the rupture. For example, as a therapist saying, I feel like something important is happening right now between us. Is it okay if we just stop for a moment and stay with that? Could you tell me a bit more how it is right now for you or what you are experiencing right now? We could also try, if maybe patients don't want to, are not so open to talking about a rupture that's happening, kind of trying to get the conversation back to it, saying, I feel like this is something that happens like a pattern. Every time that we touch upon this topic or every time this happens, I feel like you move away a little bit. Do you feel the same way? Could we agree to just give this 5 minutes of our time today? I think it's important. Things like that. And also it might be disclosing our own experience as therapists. I feel really sad when you tell me this, or when you shut down like this and you don't respond anymore, I feel really helpless. And I imagine that's also a feeling that you sometimes have. So I think there's a lot of possibilities in here. But then, as I said, this might not necessarily lead to repair or and that's why in the end of each therapy session that is coded with the 3Rs, do also a couple of session ratings. And one is to what degree were ruptures repaired over the course of the session. And there we have, again, a scale from 1 to 5. But here it's ruptures were not successfully repaired and the alliance worsened with 1 up to ruptures were repaired a good amount. And we also do code patient withdrawal, therapist withdrawal, patient confrontation, and therapist confrontation in the end of each session. And then we don't take an average score, but we give a score that we think makes sense with regard to the ruptures that they did have throughout the therapy session. Right. Yeah, are there any questions up until this point? So at least I can see your faces for a little bit and we can have some interactions.
I'll say somebody has a question, you can raise your hand. I know that many of you know the interaction, this thing here in Zoom to raise your hand, and yeah, or write the question also in the chat. Otherwise,
You're, I think, muted.
Denise, I think you're muted.
If you're talking with us. Okay.
Okay.
All right, if not, we can have questions in the end. I just feel a little lost because I'm not seeing your faces.
Hello. I always participate, but this time somebody was talking to me. No, but anyway, I think it's a very important issue, and I'm doing this webinar sort of for the first time, and I did all the other activities on this because I devote quite a lot of time in training, and I think young therapists are very, very, very inexperienced in this. So because you see they get paralyzed, and so that's why I think it's very important to provide them with tools and this kind of activities, even though they are not original within the webinars in SPR. Is very important that they come back again and again. Thank you.
Thank you very much. Yeah, I also think that, and we come to the Alliance Focus training, of course, a little bit more in depth in the end, but I do think that in many therapist trainings, there's not given a lot of explicit attention to the Alliance. But it's more something that we say like, yeah, this is the foundation. We really need this for all the interventions to work effectively. But there's not too much, I think, at least concretely, that we do to train therapists in building and maintaining the Alliance from scratch. So I think, or our hope is also that these things get disseminated more, and especially beginning therapists get more support, but maybe even advanced or experienced therapists who have maybe more very difficult cases can benefit from them. All right.
There is another question in the chat.
Yep.
I'm very sure I'm going to mispronounce this, so I'm very sorry in advance. From Cathal Young, and he's saying, as a trainee therapist, how can I bring this into practice? I'm not allowed to record sessions. What I mean is that I cannot code a session. I think it's a very interesting question as well.
Yeah. No, I totally get that this is more the exception, I think, than the rule, that you get to actually record your sessions. I think, though, that for me, actually learning, like reading the manual and coding even other sessions, or not even coding at all, but just having like a language for it, having words, having constructs where I see like, this is something that may have happened, and seeing like, oh yeah, then maybe next time I see, oh, this happened again. So it might actually be pattern. So maybe this is something I should address with my client. It can be, I think, a lot less intense than really doing like this fine-grained process, but more like having a more awareness of ruptures happening, being also clear about this can be really small things, but sometimes they can add up and lead to a bigger rupture. Or maybe if something just happens one time, we have some empirical evidence for that. We should actually also just let it go if a patient is in one session particularly withdrawn compared to their personal average, then we actually do better with regard to the alliance and outcome if we don't address it. But if someone is always a lot very withdrawn, then we actually need to address it in order for the alliance and outcome to get better. So this is also something interesting, to not say like whatever rupture there is, we need to jump at it and resolve it. But sometimes we also actually need to let it go. So it's more maybe the search for patterns, things that happen again and again in the therapeutic relationship with the client, where you're like, okay, this is really something that we need to address because it seems relevant. It might also generalize to other relationships and might be a bit of a mirror for what happens actually in relationships that they have outside of therapy. Are there any more?
think Denise.
I'm sorry. No, I have two questions because I'm not an expert in this. And as I said, I'm very keen on learning. And I have two questions. In these studies, would you have gone deep into about rupture in alliance? Are there any studies about somatic reactions in therapists in relation to this? And I relate this to Korosky is well, now he's dead, but was a very famous psychoanalyst from Argentina. He was dealing deeply into psychoanalytic, psychosomatics, and he has a very interesting paper on sleepiness on part of the therapist, which he relates to the appearance of intolerable, sinister material in the patient, for example, of a murder or something like that. So that is something I want to ask you. And the second question is there, how much has this been studied in relation to cultural humility? Because very often rupture has to do with what has been called microaggressions or not understanding the other's stance in life, values, etc. Thank you.
Yeah. So to the first, I don't have knowledge on that. However, what in alliance focused training is important is that we actually think that our initial reactions, what happens in us, often of course also physical, that's a really important and valuable source of information, and that we should not just let it go away or like make it go away, but actually be curious about it and explore it more, and not necessarily of course tell everything to our clients or patients, but really more use it as a bit of a compass. And with regard to the second, to my knowledge, there's not a lot of studies. I can think of one, which I'm happy to send you after the webinar. But I do think that often when the relationship is maybe at higher risk than typical, all the information and literature on rupture and repair becomes more relevant, because then things usually don't just work exactly the way we expect them to, right? And we might first need to actually work on the alliance before we can do our interventions. So I think maybe that for now, if that's okay, and we can do the second half. And
just a little comment. Just a little bit. Just as we insist that people who are going to be therapists have their own therapy, I think that when you are working with people from a different cultural background, you should have an analysis of your cultural paradigms, what you give for granted before, because this needs to be explored equally as your personal unresolved conflicts.
Thank you. All right, I'll then continue with the third part. And again. With to back up what I've been telling all of you, I want to also give you some empirical evidence, mostly meta-analytical for now. One meta-analysis was done by Catherine Eubanks and colleagues in 2018, and they included 11 studies with a total of 1,314 patients, and they actually found a moderate effect of rupture repair on treatment outcome. So compared to unrepaired ruptures, rupture repair had a positive effect on treatment outcome. And in this meta-analysis, they included any type of rupture measures. Also, ruptures were, at least for a long time, also measured by drops in the alliance. Although we are not sure that drops in the alliance over time or changes in the alliance over time are the exact same thing as ruptures. So they use direct and indirect rupture measures. Also some studies that use the 3RS, and that's what they found. And we thought it was important to maybe differentiate that and not only use direct rupture measures to be very certain that we actually do speak about ruptures and not a drop in the alliance. So that means we used only measures in the second meta-analysis. We used only measures that actually asked either of patient or therapist whether there was a rupture and how strong it was, or an observer-based 3RS. And we did that study last year, and we were actually surprised that we only found very few studies that reported effect sizes. And those were 5 studies in total that used direct rupture measures. So either asked patient or therapist whether or not rupture had taken place and to what extent, or used the observer-based measure that I presented before. And in those 5 studies, they reported 15 effect sizes that related ruptures to different treatment outcomes. And we did multi-level analysis to include several effect sizes per study. And with a sample of a total of 366 participants, we found a small to moderate negative effect of ruptures on treatment outcome. So we do now know, bottom line, ruptures, disregarding if they are resolved or unresolved, have a negative effect, but rupture repair has a positive effect on treatment outcome. And we're still not satisfied with that, because we actually found way more studies that use direct rupture measures than those that we could include in this meta-analysis, but they didn't report the effect sizes or enough information for us to calculate those effect sizes. And that's why we decided to do an individual patient data meta-analysis. That means that we actually asked the authors of those studies that fulfilled the inclusion criteria if they would participate and either run the same code or provide us with their data so that we can run the same statistical analysis on all of the studies. The total sample size of that is a bit about 2,000 patients, so this would be the biggest study so far. And we here are interested also in this sample, or this study would also allow us to do more complex analysis and understand what is really the association between rupture, repair, and outcome. And our hypothesis is that rupture has a negative on outcome, but it is moderated by repair, in that if repair or successful repair happens, the rupture can have a positive effect on treatment outcome and doesn't only help to get the lines or the outcome back on track to where it was before, but in the sense that rupture repair might actually lead to a better alliance afterwards. And that I think we might know that from some personal relationships, if we don't have therapeutic experiences with it, that after we talk something out, really explore, hear each other's perspectives and emotions, often the relationship strengthens afterwards. So this is actually what we expect, that unrepaired ruptures would typically lead to negative treatment outcome, but repaired ruptures would actually lead to positive treatment outcome. And we are currently still working on this individual patient data meta-analysis, but hope to submit it within the next 2 months. And yeah, please be in touch if you want to know what the outcome will be. And this leaves us with the last part of today's webinar, with the Alliance Focus training. There is a traditional Alliance Focus training that was developed by Safran, Muran, and Eubanks, and it actually was born from treatment failure. So it was the reaction to the problem that we are still facing, that a lot of patients do not actually respond to treatment, at least not directly respond to treatment. And yeah, what we can then do. This is part of the second wave, I would say, of alliance research that started about around 2000, where we decided to move a bit away from just studying the alliance and understanding more of the alliance, and all the rupture and repair research really got started. It is a training protocol that was developed for therapists, and it includes a lot of supervision and also typically group supervision. And it is, I would say, a rather it goes beyond the didactic training. It is highly experiential. And in many ways, it, for example, includes mindfulness as part of every supervision session in the beginning. It also encourages therapists to do mindfulness for their own practice, to strengthen these characteristics of awareness, of curiosity, of humbleness, that might be really important when we want to address the therapeutic alliance. And we also know that we might be part of why the alliance is not working at that moment with that particular client. It also does a lot of role play and uses chair work, where therapists are guided and help to really explore what's happening for them, what they are experiencing in relation to the patient that they are attending. And very important is, again, here the analysis of video material, so that really we don't just recall or tell each other about what's happening in therapy, but we actually really have a look at it. And one very important aspect of the therapy when we are doing alliance, when we are alliance focused, is meta communication. So we actually talk about the communication process, really exploring what is happening. And there's also meta-analysis that was done on on the effects of alliance-focused training. It unfortunately is a rather small meta-analysis, just like the one that we did recently. It only included 6 studies with a total of 276 trainees, and it was found there, this was again done by Eubanks and colleagues, that alliance-focused training had a small positive effect on patient outcome, but it was not significant. I think that's very relevant, and I think usually in all training literature, there's almost nothing that was really linked to patient outcome. Often it's linked to skill improvement, but not really treatment outcome. So I think this small effect is already good to see, but I think it's important that we also see a bit more how it works. So we are actually working on several supervision studies that are from alliance-focused training, or supervision done in the context of alliance-focused training, where we try to better understand how the supervision works and impacts outcome. And we do think that this might be via the therapeutic alliance, actually. And because we thought that the AFT might be a really important tool for therapists, we wanted to disseminate it more and have more therapists that get access to it, also because in a lot of places in the world where there's not that many resources, therapists attend clients with very, very little or no training. And so we developed together with Catherine Eubanks an online alliance-focused training where therapists are trained in recognizing, tolerating, and negotiating the alliance ruptures. And we try to do that by means of self-awareness, affect regulation, and helping them improve interpersonal sensitivity. And the deliberate practice is something that had already always developed a bit in parallel to AFT and influenced it also greatly. So including a lot of feedback and having participants practice just at the edge of where they at. So yeah, practice with examples that are just outside of their comfort zone, so to say. And we try to also integrate that even more in the online alliance focused training, where participants then receive automated feedback that's very immediate to their responses, and hoping this would also improve the effects of the training. If you're interested in getting access to the online alliance-focused training, also please write me after the webinar. I'm happy to provide you with an access code. And this is what it looks like. It's a website which compiles 6 modules, and each module takes about 1 hour. And we did recommend, or we studied it, giving therapists or participants access to them over the course of 6 weeks, with 1 module unlocking every week. And basically each of the 6 modules has 3 sub ways of training, and they also get more difficult. So the first part is always rather didactic training. I'll show you the video for repair because I was not explaining repair too much.
Let's take a look at rupture resolution processes. The purpose of a resolution process is to enable you and the patient, client, after a rupture in the therapeutic alliance has occurred, to renew or strengthen your emotional bond and to begin or resume collaborating on the tasks and goals of therapy. Resolution processes can be initiated using resolution strategies. These strategies fall into two major categories: immediate resolution strategies and expressive resolution strategies. Immediate repair strategies are efforts to promptly address a rupture and get treatment back on track, such as strategies involving renegotiating tasks or goals. Expressive repair strategies involve shifting the focus of the session toward exploring the rupture experience. For example, core relational themes that underlie a rupture. In their meta-analysis,
so this was the first part, where after each of those videos, there's also some multiple choice and open questions for participants to deepen a bit what they've learned. And then we have a second part where in each of the six modules, there's 10 example videos of patients and therapists. Here, Catherine Eubanks and Chris Muran volunteered to be therapists, and we actually paid actors and gave them a short vignette as a patient and had Chris and Catherine treat them for one session. And they didn't have a script, so everything happened rather naturally. And then we did cut those videos, and we actually found quite a lot of ruptures, but also repair strategies used. And after watching each video, which also has subtitles in English, participants can try to say which of different repair strategies or rupture markers they have seen. And they also get feedback on whether or not that was the correct or incorrect answer, or the one that we also thought was most salient. And then also once, for example, we have a withdrawal rupture, then you would also get all the options for different withdrawal rupture markers, and you can pick among them and get, again, immediate feedback on whether or not that was also what we thought. And the third part, and I think that's the most interesting part, is that we have some patient clips with difficult situations or rupture situations, I would say, that then participants are asked to directly respond to, and they record their own. So it's set up so that you record your own video online while you respond, and then we have your response there. You can watch it back, but also we can use it and code it with the 3RS and see what we saw as ruptures, markers, or repair strategies used. And this is one example I will show you.
I see. Well, you're not going to help me.
And the idea is that, of course, this gives you very little context, but that you get to really practice a lot. And there's also 10 examples per module that you can respond to as therapist. And you have, of course, also the possibility, some of them are reoccurring with different actors, and you have really the possibility to respond and practice. Maybe also try things out that you would never do in real life, and just see how that feels. And then you're afterwards asked to reflect upon that. And I think something that from psychotherapy training is a bit tricky is that usually supervision comes only after we see a client, so that live supervision is very rare, so that usually things happen. We can only get also supervision on a really small subset of cases, of course, often. And usually we start attending clients without having really practiced with clients. And this might be a rather low-level possibility to actually do practice a lot with difficult situations before we might encounter them in clinical practice. We did also study this online alliance focus training, and we're currently finishing up or writing up the manuscript. We did also recruit via the SPR listserv, so SPR has been very, very meaningful in many ways. And we did recruit 90 participants. We had 45 of those who then actually filled out the baseline assessment, and 30 who actually did the video recordings at the first time point, and then lesser every time that they completed the module, or there were always less people who completed the module. We have different hypotheses why that is. Of course, this was something voluntary. We also know we all don't have too much time just to give back. So this might be one problem. We also know that the numbers of people who answered the questionnaires or filled out the multiple choice and reflect is higher. So we also do know that there was a problem with the video recordings working on some Internet Explorers. So this is something, we did only, we couldn't solve even as we discovered it. So it's a rather small sample. And I already said that, it was a 6-week training. And we did then code the video responses of the participants with the 3RS. And we know this is a bit tricky because that's not what the 3RS was made for, but we were able to still observe some interesting things. Stay tuned for this publication. And we also do have, of course, more the self-report part of if over the course of the training participants were improving in their ability to recognize ruptures or repair, and how many correct answers they were able to get throughout the different modules. And then with the 3RS, we did code the working together subscale and the use of repair strategies on the side of the therapist, and also the effectiveness of repair. Yeah, I'm actually curious what your own take-home messages are of today's webinar. I'm curious if what your understanding is, what the mindfulness was for in the beginning of this webinar. I also would like to give you some take-home messages. The first is ruptures are inevitable. So I think that's something really important for us as therapists to be aware of, that probably whatever we do, we cannot avoid ruptures with all clients at all moments in time. And that's good. So we should also not always walk on eggshells, but just be very aware that they happen frequently, and that we do have a possibility to effectively repair them sometimes. So basically, if you see a rupture, if you're aware of a rupture, you're best positioned to address them also. Then again, I think something that's usually true with regard to psychotherapy, but again, here often it's complicated. Even if we do use a rupture repair strategy that might work with some clients, with another it doesn't, and leads to more rupture. And I think, also acknowledging our own difficulties, our own reactions with clients can be super important. I think to a certain degree, we need to not be so sure of ourselves, at least not always take our experience as the truth, but also, be really curious about what happens for ourselves, but also what is going on for the other, and be open and willing to compare and to share about that with our clients when necessary. And I think something that was my summary after being trained in alliance-focused training by Chris Muran and Catherine Eubanks was actually that I felt AFT, alliance-focused training, was more a being than a doing. So it was more like a general attitude, something that I felt more in that way than just an intervention. So I think maybe that's also a response a little bit to the question, how can I actually apply it? I think people can be very AFT without, constantly coding videos or something. Be AFT. I will, stop sharing here so that I can see all of you more, and I'm hoping we can still use the last 10 minutes to really discuss and talk about what you are interested in, what your questions are.
Thank you so much, Anna. I think it was an amazing presentation, and I think it's also a very, very interesting topic as well. I got into that, I think, not so long ago, and it was also coinciding with the beginning of my clinical training. And actually, I think one of the fears that most of us had or might have is that a rupture can happen and when I think I read one of your papers and it was like, well, if you have a rupture but you repair it, then everything is fine. And when I read that, I was like, okay, it's gonna be fine. So yeah, I think it's a very interesting topic. I have a couple of questions, but I think there are also some in the chat, and I don't know if someone wants. There I see Tally that is raising her hand. If you want to start, Tally.
Well, I first, Anna, I'm such a big fan of your work, and I think this is just phenomenal stuff. And I'm really I haven't seen the online AFT training, and it's amazing to see how far you have a package of training that's sort of ready to go. And so my question was, I do a lot of clinical training of doctoral and master's level clinical psychology students in Canada. And I've tried to integrate AFT into the coursework that the students do, but nothing that resembles like the coherent package that you've created. I know you were sort of saying that we could reach out and get access to the training, but do you have a process for faculty members to integrate that training into our courses, or to have our students complete it as and then I don't know if you provide sort of some of the research evaluation feedback back to the trainees themselves, but I would be really interested to hear if that's a possibility, or if maybe in the future that could be a possibility.
Great, thanks, Tali. I'm super excited to hear interest. And so far we have just tested in the pilot study, and we did, of course, collect a lot of data, and we don't have an ethics approach to just, so it is possible, and we will need to now anyway make a change because we won't continue collecting all this data. And I think then it's also possible. So I would say in the next couple of months, we will change it also for a project with Catherine Eubanks for September. So I think around then I could share it. Otherwise, right now, people can share if they agree to participate still in the study that's not running anymore, basically, the pilot study.
Great, thank you. Well, if you ever need test sites, let me know. Our students would be a great.
Nice. No, thank you. I will reach out once it's there.
Great. We have a question in the chat from Piero Porcelli, and it is it always alliance rupture? How can you differentiate rupture from disagreement or misunderstanding between patient and therapist?
Good question. For me, I would say if it impacts and yeah, if you cannot continue working together anymore without repairing it, then I would say it's a rupture. Yeah, I would also, again, repeat a bit the definitions. If there's a movement away or against the other, or the work of therapy, then I think we can really talk about a rupture. Of course, there's also small misunderstandings, but we've actually really said that a rupture is a small thing, or can at least be a small thing. And so I think, yeah, maybe it's a bit of a difficult line. If it's just a misunderstanding of, I don't know, the moment when you meet with the, yeah, say, maybe my question is it important if it is or not? So does it make a difference in how you work with it or how you address it? I think I would say if it impacts you working together, then probably it's a rupture. I don't know if this answers the question, but
I think I don't know if Piero is there, but for me. Yeah.
Yes, okay. Thank you very much.
Good. Thank you. And there is another question of Cathal. I work realistically using the Cooper-Norcross inventory of preferences form. One of the bipolar questions is whether you would like to work with goals or not. About half of clients prefer not to work with goals. Is the RRM still valid in that case?
Maybe you just have no disagreements with regard to goals, but I almost would doubt it. For me, also goals is something really relevant for therapy, because if not, you don't know at what point you would stop or if it was effective or not. Because if people, don't get their goals met, so yeah.
I
think
suppose what I'm just saying is
therapy for a reason, right? So so goals in the in like a very specific definition, no, I think is not relevant or necessary, but usually there is, you know, you're working towards something, or there's something that you want to get out of therapy, right?
Absolutely. I agree with you completely. And I know the research is overwhelmingly positive that goals and goal consensus is so important to good outcomes in therapy. But so many clients come in and just kind of want to just use it as a sounding board, just like let it just flow where the conversation is, how their week has been. But whenever I try and bring in the idea of goals and saying, well, what do you want to work towards? What would therapy look like for you in 6 months' time? They just don't want to go there. And I find there's a struggle with like my preference for having concrete goals as opposed to their preference to not have any goals. There's a tension there.
Yeah, I can see your struggle. I'm not sure how comfortable I would be to like, or if I would even consider that therapy or coaching, or you know, because I think, yeah, for me it's something relevant, because also when would they know it worked? You know, like what would need to happen, what need to change for clients to know that it worked, that made sense to go to therapy, that they can, you know, stop going to therapy. And I'm not talking about like goals in like symptom reduction or something that we might expect people to want to change, but I'm more like, what are their personal goals? You know, this often we know from research is interpersonal goals. They have difficulties in relationships, and actually that's why they come to therapy, but then that could still be a goal, right? So I think, yeah, I can see your struggle, and I don't have the solution. Insist on goals. But no, I think more like exploring it. What does it mean there is no goal? So it could just, everything could stay the same. Maybe make that already part of the therapy, you know.
Good. We have time for a couple of questions more, if there is more in the audience.
I think something that I've just been thinking about, and I think I didn't explicitly say it, that for me, rupture and repair and alliance-focused training is something extremely transdiagnostic and transtheoretical, and that it was developed as an adjunct to, or the original traditional AFT was developed as an adjunct to CBT. But I think now it has spread a lot, and it also has a lot of aspects with this experiential from emotion-focused therapy, for example. And we do know that from the meta-analysis that it all even worked with psychodynamic or psychoanalytic, like people originally trained in psychodynamic or psychoanalytic training, less so than with CBT, but it is actually something that can be combined, I would say, with a lot of approaches, and can be helpful with a lot of approaches, and also across diagnosis. So I think, yeah, we know that interpersonal problems is actually an aspect of a lot of psychological disorders that people struggle with and want to work with. And then this can be, I think, a really helpful tool for therapy, to also be able to really work on that, or towards a stronger relationship. Yeah. Any last minute questions?
Perhaps just a comment from my side. Here is another comment, I think from Litia. I think it will be appropriate to differentiate the rupture from the threat of rupture.
Do you want to elaborate a bit more?
I think we cannot hear you. I don't know if you are talking right now.
Yeah,
there. Amazing.
Thank you. Sometimes there is a risk of rupture that is not exactly a rupture. And maybe to understand the risk and the sign of risk, it would be very, very interesting, I think.
Yeah. And then also the question, should we take the risk, right? Because if rupture can actually lead to a better alliance than the alliance we had before, and has like a a sort of growth that might come with it, then actually we might sometimes need to take the risk, right, of rupture so that something could come out of it, like a risk that maybe we can take in our relationship with the client that outside of therapy, in other relationships, that would not work, right?
Since I think that it depends from the emotional climate, maybe sometimes that can intrude in the alliance, or there is a difference in the way the patient and the therapist see the problem, for example. Maybe we have elaborated something about the subjective theories of the patient and of the therapist that sometimes do not match.
Yeah.
And I think that it can depend from the emotional, from the content, depends. I don't know, what do you think about from what sign you have from your research about that?
I actually think there was one study conducted, but I'm not anymore sure about the authors. I'm really sorry. Where they actually found that it was the match that was relevant, and so it wasn't so important if patient and therapist both thought there was or was not a rupture, but it was the issue when one of them thought there was a rupture, but the other didn't. And I thought that was really interesting. So if they can agree there was a rupture, that's actually not the threat for the alliance or for outcome. But the problem is more when one of them sees it and the other doesn't. And to me, that made a lot of sense. I will look it up, and if you want, I'll send it to you afterwards.
Thank you very much.
Well, I think it's already time. Thank you so much, Anna, for your presentation again.
No, thank you all for your attention and for coming. It was a pleasure.
Well, with that, we can already close the webinar. Thank you very much, everybody. See you.
Thank you.